Good afternoon, everyone. Thank you for joining us today for Reena Cherry's talk on small renal masses. It's really a great honor to have you, Reena, to talk with us. So for all of you who have been joining these symposium lectures, thank you so much for supporting us in this project. And if you enjoy our lectures, continue to register, continue to follow us, tell all your friends so that we can keep this program going. All of the lectures are recorded and are posted on our YouTube channel. And so if you follow me on Twitter at EuroPA_SD, or if you follow at UCSD Urology, you'll see the tweets with the links for the YouTube channel and where you can find the recordings. If you go to YouTube, you can also search for APPs and Urology Symposium, and you can find our channel that way as well. If throughout the lecture you have any questions, you can use the Q&A button at the bottom of the screen. We are going to save the questions until the end of the lecture, but you can go ahead and start asking those questions and we'll bank them for the end. And if there are any issues with broadcast, if you can't hear, if there's any concerns, then you can also use that Q&A section as well to communicate with us. Okay, so to introduce Reena Cherry is a board-certified physician assistant who holds over 20 years of experience in the field of oncology. Her previous practice areas include reconstructive plastic surgery, dermatology, and head and neck surgery. Over the past 10 years, she has narrowed her clinical focus to urologic and GU medical oncology, with expertise treating prostate, kidney, and bladder cancer. Reena is a native San Diegan, but ventured outside of her favorite city and state to receive her education. She earned a Bachelor's of Science in Psychology at Spelman College in Atlanta, and went on to earn a Master's of Science degree at Baylor College of Medicine in Houston. Immediately following graduation from Baylor, she was offered a position at MD Anderson Cancer Center, where she worked with world-renowned oncologic surgeons, medical oncologists, and radiation oncologists. Reena recently returned back home to San Diego and is proud to have joined the GU Medical Oncology team at UCSD. When she is not serving patients at Moores Cancer Center, she enjoys running, cycling, and spending outdoor time with her husband and two beautiful children. And without further ado, I'm going to pass it over to Reena. Thank you so much.
Well, thank you, Rachel. That was a lovely introduction. Again, my name is Reena Cherry, and I'm excited to talk to you all today about incidentalomas. So these are small renal masses that pop up on CT and MRI imaging when we are trying to evaluate something completely different. And I find that many clinicians and also patients get concerned when these pop up. We want to know what to do with these and what the treatment strategies are. So I'm hoping to answer those questions for you today. So without further ado, we'll get started. These are my learning objectives. I will review kidney anatomy a little bit. Being familiar with the anatomy of the kidney and knowing the location of your renal mass is really critical in how we approach these lesions. I will also spend a lot of time talking about renal cysts. These pop up all the time, and I get a lot of questions from patients and other clinicians about what to do with these. So we'll spend some time talking about cysts, and I'll also talk to you about a few other benign renal lesions that we see on imaging. I will spend a little bit of time talking about renal cell carcinoma. It's hard to do a lecture about small renal masses and not touch on renal cell carcinoma a little bit. So we'll talk a little bit about that. And I'll also talk to you about treatment recommendations for those suspicious renal masses. So to review a little bit of anatomy with you, the vast majority of the lesions that I will be speaking to today arise from the renal parenchyma. So the parenchyma is this light brown colored area around the kidney. It's also known as the renal cortex. Now, there is a very rare form of kidney cancer that arises from the medullary portion of the kidney. So the renal medullary are these pyramid-shaped areas within the kidney. That's a very serious malignancy, and I'll touch on that in a little bit. Radiologists also point out lesions that are close to or are abutting the renal hilum. So it's important to know what those structures are. So the hilum contains the renal artery, the renal vein, and also the renal pelvis and the ureter. And certainly we need to be very careful and cautious about treating lesions that are close to the renal hilum. I also want to point out that malignancies, these small renal cell carcinomas that I will be talking to you about today, that arise from the renal parenchyma are very, very different from malignancies within the kidney that arise from the urothelium. So we want to make sure we know the difference. Once again, the urothelium lines the renal calyces. It also lines the ureter, the bladder, and also the urethra. So if we're concerned about a malignancy that arises from the urothelium, those are urothelial carcinomas, and they're treated very, very differently than we treat adenocarcinomas of the kidney or malignancies that arise from the parenchyma. Now, when you're reading radiology reports and the radiologist is describing the location of a renal mass, it's nice if we know exactly where they're talking about. So they use different descriptors, and one thing that they'll do is talk about the poles of the kidney. So when they talk about the upper pole of the kidney, they are describing renal lesions that arise above the renal artery. When they're talking about the lower pole of the kidney, we're down here and talking about renal lesions that arise below the renal vein. Anything in between is known as interpolar. Now, I want to make a note here that the location of the renal tumor is critically important. So I like to, when I'm talking to students in clinic, I always tell them to think about renal lesions like real estate. It's all about location. So, and not so much the size of the tumor. So as an example, if I have a 5-centimeter renal tumor and it's rising down here in the lower pole of the kidney, that patient can actually undergo a partial nephrectomy. We can spare nephrons and everyone is pretty happy. If I take a smaller tumor though, and I place it here, still arising from the parenchyma, but now very close to the renal hilum, now we're in jeopardy of damaging the blood supply or the collecting system of the kidney. And that patient, if that lesion is suspicious, may be relegated to a radical nephrectomy. So really the location of the tumor is very important, and oftentimes it's a little bit more important than the size of the lesion. Okay, so getting into our benign renal lesions, I'm going to talk again about renal cysts, and we'll talk about the Bosnian Criteria. I'll also talk about renal oncocytomas and angiomyelopomas that are benign lesions that we can see. So renal cysts and the Bosnian Criteria. The Bosnian Criteria was introduced in 1986 by Dr. Morton A. Bosniak. And he created the criteria as a way of determining and strategizing how best to treat these cystic renal lesions that we see on imaging. The Bosniak Criteria uses morphology and also enhancement characteristics to place the cysts in one of 5 categories. So there's Bosniak type 1, 2, 2F, 3, and 4. Now, lucky for you, the only criteria I want you to focus on is Bosniak type 2. If you remember what to do with Bosniak type 2 renal cysts, you will know what to do with all of the other cysts that land in other categories. So let's review what's in this Bosniak classification system. Bosniak types 1 and 2 cysts, these are our simple cysts. They look like water balloons on the kidney. They have either no calcification or very thin areas of calcification. They have either no septa or very few septa. So when we talk about septa, we're talking about little cobweb-like structures that arise or develop within the kidney. And most importantly, the simple cysts do not have any enhancing qualities. So Bosniak type 1 and Bosniak type 2 renal cysts, we get to completely ignore. They never undergo malignant change. They're never worrisome, so we can totally ignore those cysts. Now, Bosniak type 2F category cysts, that's the category I really want you to remember. The F stands for follow. So we are going to follow these cysts about every 6 months with imaging. Now, why are we doing that? We need to follow these cysts because these cysts are developing areas of calcification that don't technically enhance now, but may undergo malignant change later. So it becomes important to follow these cysts closely. So Bosniak type 2F, we are going to follow. Anything higher than a Bosniak type 2F cyst is a surgical referral. So these are cysts that look very concerning for malignancy and need to be resected. So Bosniak type 3, these are more complex cysts. The cystic walls are thickened. There are many septa with very thickened walls, and we're starting to see areas of enhancement within these cysts. Bosniak type 4 cysts actually start developing soft tissue components within the cyst. And we'll see some examples of that in just a minute. So here's a really nice example of a Bosniak category 1 cyst. Our cyst is here. This is the dark lesion here. The cyst is just filled with normal body fluid. There's no septa. So this is a category 1 lesion. Now we're going to jump to Bosniak type 2F cysts. So on the left, you'll find this long arrow pointing to an area within the cyst. So here's the kidney here, this little wider area, and the cyst is this darker lesion down here. And the arrow is pointing to an area of septal development that's starting to develop a little bit of calcification that's worrisome. And so the radiologist has classified this as a Bosniak type 2F cyst, and we're going to follow this lesion. And sure enough, we did CT imaging about 6 months later, and you can see the same area of the cyst has continued to evolve. We have now many more septa, and we're starting to see some more thickened areas. So this patient, I believe, went on to have a partial nephrectomy, and the diagnosis was cystic renal cell carcinoma. So it's just a nice slide to show you how these cystic lesions can evolve over time. This is a classic Bosniak type 3 cyst. You'll see on the left kidney here. So this cyst has got thickened walls. It's got many septa. The septal walls are thick. And here we start to see calcification with a little enhancement. So this is definitely a concerning cyst that needs to be surgically resected. And this is our category 4 Bosniak category 4 cyst. This cyst contains all of the characteristics we just mentioned with a few extras. So the long white arrow here is pointing to an area of mural calcification with enhancement. So this is what we're concerned will develop with our category 2F cysts. And then the short squatty arrow here is pointing to the soft tissue development within the cyst that I mentioned earlier. And I'm a visual learner, so I like to sort of make comparisons. To me, this looks like almost like a water balloon with some cotton balls inside of it. So when you see this type of a cystic lesion on imaging, this is a category 4, Bosniak category 4 cyst, and this patient needs to be referred for surgery. So just to summarize, again, our Bosniak type 1 and type 2 cystic lesions, these are friendly cysts, they're simple cysts. We don't need to follow these ever. They're not going to undergo malignant change, and we can ignore these. Bosniak type 2F cyst, again, the F stands for follow. We're going to follow these cysts every 6 months with CT or MRI imaging. Bosniak type 3 and 4 renal cysts are concerning for cystic renal cell carcinoma, and those patients need to be referred for surgery. Okay, so moving on, we're going to talk a little bit about renal oncocytomas. This is another benign lesion that can arise from the kidney. Oncocytomas are vascular lesions, so they actually enhance on imaging, which makes them really tricky to differentiate between renal cell carcinomas when you're looking at CTs and MRIs. Now, the images that I have for you here are pointing to, this thin arrow here is pointing to an area of centralized scar. When the radiologist can find the centralized scar on imaging, they're quite happy because they can actually make the diagnosis of oncocytoma based on imaging alone. The bad part about this is that it's really rare to be able to see the centralized scar on imaging. So most of these patients end up getting evaluated and worked up as if they have a renal cell carcinoma. They'll undergo treatment, and typically we get the diagnosis based on surgical or procedural path. Oncocytomas can also continue to enlarge over time. So even if we capture these, we think we're looking at an oncocytoma, or if we get a biopsy and the biopsy confirms oncocytoma, we still need to follow these, because if they get a little bit too big, we're definitely going to want to send this patient for a partial nephrectomy if we can, so they don't have any localized issues. Renal angiomyelopomas. So radiologists love to see these because they get to come in like superheroes. Renal angiomyelopomas are the only renal lesions that a radiologist can definitively diagnose on imaging alone, and that's because these are fat-containing lesions. It's the only fat-containing lesion that arises from the kidney. So once the radiologist identifies fat within a lesion, they know they're looking at a renal angiomyelopoma, and they can make that diagnosis. Now, renal angiomyelopomas also contain blood vessels, so they're vascular lesions. So even though they're benign, they can continue to enlarge over time. And if they get too big, these lesions are at risk for spontaneous hemorrhage into the retroperitoneum. So we do follow angiomyelopomas every 6 months with imaging, and we intervene when they get a little bit too big. Typically, we like to recommend treatment once the AMLs get to about 3 centimeters in size. Now, this slide that I'm showing you here is pointing towards a larger angiomyelopoma. Unfortunately for this patient, it's located in the renal hilum, so this patient would be a candidate either for embolization or radical nephrectomy. All right, renal cell carcinoma, we're going to talk a little bit about this. In 2019, approximately 74,000 cases of renal cell carcinoma were diagnosed, and of that, about 15,000 patients ended up dying of kidney cancer. This disease tends to present in the 6th to 8th decades of life. It is rare to diagnose kidney cancer in patients who are under 40 years of age. However, I will tell you that we're diagnosing many more younger patients with smaller lesions because we're getting so many CTs and MRIs for other medical issues. The 5-year survival rate for localized tumors is really pretty good, upwards of about 85%. However, that overall survival rate drops to about 20% in locally advanced lesions. We still hold a male to female ratio of about 2 to 1 for renal cell carcinoma, and the risk factors include smoking, obesity, hypertension, diabetes, and also environmental exposures. Please be careful when you're looking at patients who either work in a chemical plant, work around chemical plants, or work with paint thinners and solvents. Those patients are at risk for GU malignancies in general, but also specifically, for renal cell carcinoma. All right, so I'm going to talk a little bit about histology because that does play into some of the benign lesions that we talked about earlier. About 80% of all renal cell carcinomas are clear cell type. So this is definitely the most common type that we see. Papillary RCC is the second most common type that we see. And it's important to note that papillary RCC tends to present in a multifocal pattern. These lesions are also hypovascular. So if you're reading a radiology report and you are reading that the radiologist says the lesion is multifocal, hypovascular in nature, but looks suspicious, you should think papillary RCC. It also tends to be a little bit more common in African Americans. Chromophobe RCC, from a histologic standpoint, very closely resembles renal oncocytomas, so that's important to note. Cystic RCC is by far my favorite type of kidney cancer, and that is because it does not ever metastasize. So this is another bit of education to keep in your toolkit for patients. So if you are evaluating patients who have cystic lesions and they are concerned about the chance of malignancy, you can assure them that even if that cystic lesion is consistent with cystic RCC, there's no risk of metastatic disease. There's no risk of metastasis. So you can calmly kind of work through that with your patients. Sarcomatoid RCC, it's very aggressive. These patients tend to present with more locally advanced lesions. They also tend to present with metastatic disease right out of the chute. Now, medullary RCC, I will take a moment to talk about this type of renal cell carcinoma. This is a devastating diagnosis for patients. It's exceptionally rare, but when you do see it, it is devastating. So patients with medullary RCC carry the sickle cell trait. So in the literature, you'll read that this type of kidney cancer has a 100% penetration for the sickle cell trait. So what does that mean? It doesn't mean that every person who carries the sickle cell trait is going to develop medullary RCC. What it does mean is that almost 100% of patients who are diagnosed with medullary RCC carry the sickle cell trait. The other devastating thing about this disease is that it tends to affect patients who are very young. So these patients are in their mid to late 20s. Occasionally, we will see patients in their early 30s. So you're looking for young patients. And I also want to just mention that African Americans more commonly carry the sickle cell trait, but please keep in mind that patients of other ethnic backgrounds can also carry the sickle cell trait. So you're looking for a young patient with a locally advanced renal mass who carries the sickle cell trait. If they meet those 3 criteria, you're to think medullary RCC. That patient needs a very good biopsy and a referral to an academic center so they can get started on chemo immediately. Most of these patients do not live longer than a year. So it is a devastating diagnosis, but if we can capture it early enough, we can try to improve the quality of life for these patients. Okay, small renal masses, diagnosis and treatment. So when I talk about small renal masses, these are masses that measure 3 centimeters in size or less. And I just want to add that in the literature, you'll read commonly that suspicious renal, or not suspicious renal lesions, renal cell carcinomas that measure 3 centimeters in size or less have an almost 0% chance of metastasis. And so you want to keep that bit of information in the back of your mind as we move forward with the evaluation and treatment of these lesions. It's also something to go ahead and share with patients because it does, make them feel better. So imaging studies, I get a lot of questions about what imaging to use and when to use it. The gold standard technique for monitoring a renal mass is to use CT imaging. Now, why are CTs so great? CTs are great because they are inexpensive, they are fast, and they give us really good soft tissue discrimination, all things that we need to evaluate renal masses. Now, we do need to be careful for patients who have compromised renal function. In order for radiologists to identify a renal lesion that is enhancing, they require a non-contrast as well as a contrast CT in order to calculate Hounsfield units. So we are going to be giving contrast to these patients, so please be aware of their renal function. You also want to be aware of the overall radiation exposure for patients, and this is particularly important for our younger patient cohort. If you know that a patient is going to be getting CT imaging for either their renal mass or perhaps for a concurrent malignancy or diagnosis, you want to make sure that you're not really overdoing it with CTs, and that's when we'll use MRIs. We'll kind of toggle between CTs and MRIs for some of our younger patients. Now, when do we use MRIs? So MRIs give excellent soft tissue discrimination. The reason we don't use them as often is that it's a very expensive study. We've also heard from patients that it's a long study and it's a very tight tube. So it's anxiety provoking for patients, it's very expensive. So we tend to save MRIs to evaluate renal lesions that either A, may have vascular involvement. So if we're concerned that a renal mass is invading the renal vein, we will go ahead and get an MRI. Also, if we're evaluating cystic lesions that appear to be a little bit more dense. So what I didn't mention in my cystic portion of the lecture was hemorrhagic cysts. So hemorrhagic cysts are technically Bosniak type 2 cysts, but they can appear more dense on imaging, CT imaging. So if a radiologist is at all on the fence, we'll go ahead and order an MRI, and it's usually pretty easy for them to discriminate between those two with MRIs. Obviously, you want to use MRIs for patients who have contrast allergy. It's also an excellent modality to use for patients who have compromised renal function. All right, so biopsy or not to biopsy. This question pops up a lot. I will tell you that in general, this is surgeon dependent. I've worked with urologists who lean on biopsies a lot. I've worked with others that don't use biopsies as often. For the most part, if you're looking at a suspicious enhancing renal lesion and the patient is a good surgical candidate, we'll go ahead and refer that patient for surgery or recommend surgery for those patients. But there are particular reasons why we will pull the trigger on a biopsy. One reason is if a patient has a pre-existing diagnosis, malignant diagnosis. So if you're looking at a patient who's got colon cancer or breast cancer or lung cancer, and you are at all unsure of whether or not we're looking at a metastasis involving the kidney, we'll go ahead and get a biopsy to confirm. Lymphoma, suspicion for lymphoma is a big one. Lymphoma is not a surgical disease. So if we are concerned that the patient has lymphoma with renal involvement or kidney involvement, we'll go ahead and get a biopsy of that lesion. If the biopsy confirms the presence of lymphoma involving the kidney, we'll refer appropriately. Otherwise, we'll move on with other treatment modalities. Patients who are at risk for post-op dialysis, those are patients for whom we'll almost always get a biopsy because we want to be doubly sure that we're treating a malignancy if we're going to put the patient at risk. Also, patients who present with a solitary kidney. So this doesn't happen often, but most of us in urology have seen it at least a couple of times. patients can present with either one lesion on their solitary kidney or multifocal lesions on the kidney. So for those patients, we'll go ahead and do a biopsy. And then lastly, and this ties into the first slide we were looking at with the renal anatomy, if we are concerned that a renal tumor is arising from the urothelium and not the parenchyma, we will pull the trigger on a biopsy, but it's a ureteroscopy with biopsy and not a percutaneous biopsy. The reason for that is that if that lesion is consistent with urothelial carcinoma, we prefer to keep that malignancy within the GU tract. We don't like to get percutaneous biopsies on urothelial carcinoma if we can help it. So please keep in mind, if you are at all concerned that a lesion is consistent with urothelial carcinoma, you want to refer for ureteroscopy with biopsy. Okay, so treatment factors to consider when we're managing patients with renal masses. Certainly age plays a part. If we're looking at a patient who is much, much older or maybe in their 80s, we might decide to do active surveillance versus being more aggressive with a surgical recommendation. Performance status, renal function, those are important, obviously. Medical comorbidities. So, and I'm sorry I didn't highlight this on my slide, patients who have long-standing hypertension or diabetes, you have to be really careful with these patients. They are not going to rebound their renal function nearly as well as our younger, healthy patients without these diagnoses. So you want to be very careful about patients who have long-standing hypertension and diabetes, and certainly also patients who carry a concurrent diagnosis, a malignant diagnosis. Most of our small renal masses, as I discussed, especially if they're 3 centimeters in size or less, those masses have a very low risk of metastasis. So we can prioritize the other malignancy, make sure that patient gets through their treatment safely, and then we can pivot and address the small renal mass later. So tumor factors to consider, again, just like real estate, location, location, location is so important. Also the size of the tumor. And the rate of growth is also important. So your average renal cell carcinoma, clear cell RCC, grows at an average rate of 3 millimeters a year, which is a relatively slow growing lesion. And so we really do have tincture of time for some of these, 1 to 1.5 centimeter renal lesions. We really don't have to pull the trigger on treatment unless or until that lesion gets to about 3 centimeters in size. And then certainly we consider biopsy results if they're available. So just to review NCCN guidelines for how to treat small suspicious renal lesions, partial nephrectomy is the gold standard. So if we are evaluating and determining treatment recommendations for a small lesion that appears consistent with renal cell carcinoma, nephron-sparing surgery is the gold standard. We have found that patients do much better over time with more nephrons than fewer, and so we're always looking for ways to do a partial nephrectomy, either robotic or open is fine. We will do a radical nephrectomy if we have to, but there's no difference in overall survival for patients who have, or disease-free survival, for patients who have radical nephrectomy versus partial nephrectomy. So active surveillance, again, is very appropriate for specific patients. I'll get into that in just a minute. And then energy ablation techniques I'll talk about also. That's a great way to manage some of these small renal masses. All right, so let's talk a little bit about active surveillance. Yes, it is safe to watch and wait, and patients always look at me a little crazy when I start to talk about active surveillance, but you really have to engage in patient education when you're talking about this. So the reason active surveillance is appropriate is because we're equipped with 2 pieces of information. We know that renal masses suspicious for RCC that are 3 centimeters in size or less have an almost 0% chance of metastasis. I think the number that you read in the literature is anywhere from 1 to 2%. We also know that these renal lesions tend to grow at about 3 millimeters per year. So armed with those 2 pieces of information, we can very safely manage patients on active surveillance, let them finish up additional treatment for another malignancy, etc. We don't have to rush. Now for these patients, we're doing imaging every 6 months with either CTs or MRIs, whatever you've deemed appropriate. We're also getting labs and a chest X-ray to complete that evaluation. Again, these are for small renal masses, anything over 3 centimeters in size, and you're really talking about treating these lesions, not watching and waiting. And active surveillance obviously is great for patients who are poor surgical candidates or who are undergoing treatment for another malignancy. Renal ablation. So energy ablation is a great technique to use for renal masses for patients who are not appropriate for the OR. Radiofrequency ablation and cryoablation are the mainstays of energy ablation. RFA uses cautery effect to kill those cancer cells in the kidney. Cryoablation obviously uses the formation of an ice ball to kill the cancer cells on the kidney. And it's critically important, these patients get referred to interventional radiology for energy ablation, and it's important for the interventional radiologists to do these procedures on small renal masses, anything larger than about 3.5 centimeters in size, and we risk not being able to treat that entire tumor. So size is very important. The other important thing to note is that when the interventional radiologists perform ablation, they are very typically performing a biopsy immediately prior to the ablation. And that is because you always want to know what it is you have ablated. So having pathologic confirmation of that mass is important. And it's just great for the patients to be able to do a biopsy and then immediately thereafter go ahead and have the ablation done. All right, so this slide I was able to borrow from my very good friend, Dr. Sabir, who worked with me at MD Anderson Cancer Center. And I love this slide because you can actually see these radiofrequency ablation prongs inside this renal mass. You see the renal mass here is this sort of darker structure on the kidney, and then you see the prongs of that RFA probe going into that mass. And you can also see from this slide that if this mass were a little bit bigger, we would risk not being able to get the prongs to the perimeter of the mass, and we would risk not treating the entire lesion. All right, so this is another slide I borrowed from my friend Dr. Sabir. This is a slide of cryoablation. So again, you can see the cryo probes, these metal probes here. You can see a really nice ice ball form here. And then you can also see the thermal effect going on in the kidney, which I think is pretty amazing. So this is what happens during cryoablation. Now, partial nephrectomy, again, is our gold standard for treatment of suspicious renal lesions. And, you know, nephron sparing is very important for patients long term. So I keep the slide in, one, because I think it's a very good teaching slide, two, because I like to irritate one of the surgeons I used to work with who thought the slide was just a gross oversimplification of what happens in the OR. So he hates this slide, but I love it because it's great for teaching. So you can see here on the left that you have a suspicious renal mass, and the surgeon has annotated this very nice perimeter with a marking pin around the mass. You can also see the bulldog clip here. So it's important to actually clamp the renal artery before doing a partial nephrectomy to avoid massive hemorrhage during the surgery. Here on the left, you can see that the resection's been performed and you have a thin rim of nice healthy tissue on the back of that specimen. And again, you wanna make sure that you have hemostasis before you unclamp the bulldog. All right, so this is just a very brief study. This is a study on the benefits of nephron-sparing surgery. This was done at the Mayo Clinic back in 2000. They essentially took 164 patients, half of whom received a partial nephrectomy, half of whom received a radical nephrectomy, and they looked at how those patients did over time. There was no difference in disease-free survival. There was no difference in the incidence of metastasis or local recurrence. However, the patients who had radical nephrectomy did poorly with respect to chronic renal insufficiency, management of hypertension, presence of proteinuria. So again, we have to look at the longevity of our patients and do what is best for them long term. And certainly a nephron sparing approach, either robotic or open, is most appropriate. So just to wrap up with partial nephrectomy, again, we're looking at small amenable tumors. We can also do partial nephrectomy, as I stated before, for larger, more peripherally located tumors. Robotic approach is becoming the standard of care, although I will say that, you know, this is surgeon dependent. So if you're working with a surgeon who's primarily done open partial nephrectomies, those patients from a recurrence-free survival do just the same. Obviously, patients like robotic surgery a little bit better, the recovery is better, but you can assure them that as far as their disease-free survival is concerned, there is no difference. And then we still use like I said, open approach for more complicated resections. All right, so just to wrap up what we've talked about today, remember when you're looking at your cystic lesions and the Bosnian criteria, I only want you to remember Bosniak type 2F. Anything that is lower than a Bosniak 2F is a simple cyst. You can ignore those cysts. You don't have to follow them. Bosniak type 2F category cysts, you're going to follow with CTs or MRIs every 6 months. Biopsy, yes, we do biopsy renal masses when we feel we need to, and we reviewed those reasons. Imaging studies, just remember CT imaging is the gold standard for small renal masses, but we do use MRIs if we're looking for vascular involvement or if we're trying to discern a hemorrhagic cyst versus a solid enhancing lesion. Active surveillance is appropriate, and it does buy you time so that you can allow patients to move forward with treatment for other issues before you tackle these small renal masses. Energy ablation is perfect for patients who are not good surgical candidates. And again, RFA and cryoablation are the mainstays of energy ablation. And partial nephrectomy is the gold standard of care for patients who are surgical candidates for small renal masses. Again, robotic surgery is fantastic, but an open partial nephrectomy gets you to the same goal and is very good care for those patients. So that's about it. Thank you for your time and attention. I'm happy to take any questions.
Wonderful, Reena. That was really, really enlightening. Thank you so much. And those were fantastic slides. Okay, so anybody with any questions, please go ahead and use the Q&A section at the bottom. We'll get started with the few that have already been asked. Okay, so first question, Reena, are there thresholds for intervention for simple renal cysts? So for example, patients might get worried about leaving them alone. They might have a fear of them rupturing.
Yeah. So in my experience, we do not recommend treatment for simple cysts unless they are extremely large and symptomatic for patients. So we can intervene. Our surgeons have gone in and performed surgery on some of these cysts and actually just tried to remove the fluid, either surgically or, and that's the best way to do it. It's just the best way. So, you know, interventional radiologists, I think, are a little leery of trying to remove fluid from a cyst because you don't want uncontrolled leakage of cystic contents in the retroperitoneum. But in my experience, a lot of times these cysts will come back. So we try to really hold off on treatment of simple cysts, like I said, unless the cyst is very large and the patient is symptomatic, at which point sometimes we'll pull the trigger.
Great. And then for patients who have renal insufficiency or who have end-stage renal disease, let's say who have been on dialysis for a period of time, what do you do with regard to imaging when a patient is, we know that those patients have a higher risk of malignancy. So what do you do in terms of what's the best modality to image those patients, considering they may not have enough excretion to be able to identify enhancement, for example, contrast enhancement?
Sure. So for patients who are actually already on dialysis, a lot of times we'll go ahead and get a CT with contrast, and the patients will just schedule their dialysis immediately after. So we have seen many of those patients. It's a little bit tricky trying to make sure they get their imaging studies and then they have something lined up for dialysis right after. But we do use contrast imaging for patients who are on dialysis. You just have to make sure that you help them set up dialysis immediately after so that they can go ahead and get the contrast dialyzed.
Okay. And then next question, and I think you covered this a little bit, Reena, but if you wouldn't mind just reviewing or going over it.
Sure.
One of our participants mentioned that she joined late, but she's wondering what the recommendation is for follow-up on angiomyelopomas.
Yeah, so angiomyelopomas, again, they can continue to enlarge over time. We typically don't pull the trigger on treatment of AMLs unless or until they get to about 3 centimeters in size. When they get larger than that, those AMLs are at risk for spontaneous hemorrhage, and we'll go ahead and treat. It's also easier to treat an AML when they're smaller and not larger. And so treatment options, again, for an AML are surgical resection or embolization.
Great. And then one of our participants also had a question about embolization and what is the duration of, he asked what's the duration of the procedure.
I do not know. That's a great question. I don't know. I can get the answer. Actually, I can get that answer. And if they want to just include an email address or something, I'm more than happy to provide them with that information.
Wonderful. Okay. Well, thank you so much, Reena. This has been fantastic. I don't want to take up too much of everyone else's time. For any outstanding questions, I'll go ahead and send those to you, and and Reena can respond personally. Again, go ahead, and if you'd like to review these slides or this lecture recorded, you can follow us on our YouTube channel. You can either search for APPs in Urology Symposium. You can also follow me on Twitter at EuroPA_SD or at UCSD Urology for the links, which will be posted later tonight. And go ahead, tell your friends, let everyone know that this is a program that they should listen to and tune in to. We're having a really good time putting on the program. I hope you all are enjoying listening, and we look forward to seeing y'all next week.
Thank you so much. I appreciate it.